Welcome to the Medical Nursing Unit. Topic 1, Disorders of Respiratory System. The second pathology we are going to see in respiratory disorders is bronchiectasis. The bronchiectasis, this is a chronic irreversible dilation of bronchi and bronchioles that may be caused by a variety of conditions, including pulmonary infections and obstructions of the bronchus, aspiration of foreign bodies, vomitus or materials from the upper respiratory tract, pressure from tumors, dilated blood vessels, and enlarged lymph nodes. A person may be predisposed to bronchiectasis as a result of recurrent respiratory infections in early childhood, measles, influenza, tuberculosis, and immunodeficiency disorders. Pathophysiology of bronchitis. The inflammatory process associated with pulmonary infections damage the bronchial wall, causing a loss of its supporting structure and result in thick sputum that ultimately obstruct the bronchi. This ultimately can cause the alveolar distal to the obstruction to collapse at atelectasis. Okay. What are the clinical manifestations? We have a chronic cough with purulent sputum in a copious amount. We can also have hemoptysis, also repeated episode of pulmonary infections. Let's summarize the pathophysiology of emphysema. We will have hyperinflammation of alveoli and destruction of alveolar walls. There will be a destruction of alveolar capillary walls, narrowed airways, and loss of lung elasticity. This is pathophysiology of the emphysema. We have two types of emphysema. The first is the panlobular emphysema. In this kind of emphysema, the bronchioles, alveolar ducts, and alveoli are destroyed, and the air spaces within the lobules are enlarged. When we say centrobular emphysema, the pathologic changes occur in the lobules, while the peripheral portions of the sinus are preserved. The clinical manifestations of emphysema. We have dyspnea, progress in severity. Patient will first complain of dyspnea on exertion and progress to interfering with activity of their breathings and rest. Minimal coughing with no too small amount of sputum. Overdistension of alveoli causes diaphragm to flatten. Patient becomes chest breather, relying on accessory muscles. Ribs becomes fixed in inspiratory position. Patient is underweight despite adequate calories intake. What are medical management for emphysema? The major objectives of treatment are to improve the quality of life, to slow the progression of the disease process, and to treat the obstructed airway to relieve hypoxemia. Let's continue with the bronchial asthma. Asthma is a medical condition characterized by airflow obstruction. This is narrowing that vary markedly both spontaneously and with treatment. Understand that the asthma, this is a chronic disease, but by giving the treatment can be the obstruction can vary and can even be reduced, can even be reversible. What are these factors and triggers involved in asthma? Because the asthma is allergic disease, we can have endogenous factors. In endogenous factors, we have a genetic predisposition. The genetic predisposition, this is it, we can have atopy. The atopy is the patient with atopic disease, particularly allergic rhinitis, the rheumatitis, are at risk of developing asthma. Those are people who have allergies, most of the time, sinusitis, rhinitis, they may also develop asthma. Also, we have air hyper-responsiveness. When we say hyper-responsiveness, is such hypersensitivity. The hypersensitivity means what? When the bronchi senses the allergen. We have the allergen. When we say the allergen, this is the particular thing, that can cause hypersensitivity of the bronchi. Look, okay, while we are treating the client of the asthma, most of the time it is very important to identify which condition, what causes allergies. That cause allergy is allergen, and called hyperresponsiveness. When we say hyperresponsiveness of the body, we will have an inflammation responses. I think you understand it very well. So yeah, when the body senses the foreign body, they respond by inflammation. The inflammation, what is the inflammation? This is there will be accumulation of the blood at the site. Since the allergen, there will be a recruitment of enough blood to bring at the site the antibodies and the macrophages. Okay, when the much blood accumulated in such location, such area, we will have a redness and heat. Those are the first signs of inflammation. They occur because of the accumulation of the blood. We know very well the heat are secreting the blood. Yeah, the blood carry the heat of the body. When the blood accumulated at one site, it is understandable that the heat will increase. That's we understand the heat when there is inflammation. And what is the redness? The sign of redness, how it is occur. We know very well that the blood is having the red color. The blood accumulated in the area. The volume increased of the blood in the one area. Now those accumulation will appear outside. So the redness, this is the color of the blood accumulated in such area. Okay, the third sign of inflammation is swelling. The swelling. Now, how the swelling will come? Now we understand. When the blood, there is extra blood accumulation in such area, it's understandable that it is an increase in the volume. So there is a swelling. And the last one is the pain. Those accumulations of the blood now will compress the nerve at the site and will feel pain. Those are the pathophysiology condition of the inflammation signs of inflammation. So those signs of those conditions of inflammation will also happen in the bronchi with the hypersensitivity. When the client meet or breathe in the allergen, we have understand that the things that cause allergy to the person. Now the body will respond. The response will be inflammation. The site will be will produce the heat. There will be redness and always swelling and even pain. That swelling in the bronchi will tend to obstruct the bronchial tube. Now the tube will try to obstruct the tube. So when they try to plug the tube, now for asthma, the client will inhale, no problem. But for exhalation, the air will be trapped by obstructions. I think it is understandable. Yeah. Okay. So when we say airway hyperresponsiveness, this is hypersensitivity. Yeah, it is an inflammation response. We have also environmental factors. This is indoor allergens, as we have said. Outdoor allergens, occupational sensitizers, such as the small animals allergens in the laboratory workers and the fungal. amylase in the wet flower in the bronchus. We have passive smoking, respiratory infections, obesity. Obesity also is an independent risk factor for asthma, particularly in women, by the mechanism as that's for unknown. We can have early viral infections. Early viral infections can cause asthma also. Now, the triggers, this is allergens. I explained the allergen. This is the things that can cause hypersensitivity to the body. Upper respiratory tract viral infections, exercises and ventilation, cold air, sulfur dioxide, and drugs. What drugs that can cause asthma, which is blockers, aspirin also. Yeah, when the client is having asthma, for any client with a history of asthma, we can't give the aspirin. Now, stress and strong emotions can also cause asthma. Irritant. The irritant also displays paint, fumers. It can also cause asthma. Menses in some women is also, when they are in the menstrual period, it can also cause the asthma. Gastroesophageal reflux disease. Now, this is returns back of the what they call the gastric content. Now this is a gastroesophageal reflex. Now can cause allergy to the bronchi and develop the asthma. Okay. Now, well, the clinical features of the asthma. The characteristic symptoms of asthma are wheezing, wheezing and dyspnea and coughing, which are variable, both spontaneously and with the therapy. So if the client enter with the wheezing, now you can administer the bronchodilator in a few minutes. You will see there is a variability now. The wheezing reduced and the dyspnea reduced. Okay, symptoms may be worse at night, and the patient typically awake in the early morning hours. Now, at the beginning of this disease, the client can come and tell you, now I don't breathe. Now when I sleep, I don't breathe well, and I am conditioned to sit down. To sit down. And also in the signs of obstruction now, the signs of dyspnea occur early in the morning. The patient can report difficulty in filling the lungs with the air now. There is increased mucus production in some patients with typically tenacious mucus that is difficult to expectorate. There's increased ventilation and the use of accessory muscles of ventilation also. Okay. What should be differential diagnosis for asthma? When we say differential diagnosis, this is the disease that can have a similar symptoms with that disease. When we have upper airway obstruction, may by a tumor or laryngeal edema can mimic severe asthma, but patients typically present with stridor. Now, before I explain the difference between wheezing and stridor, and wheezing is specifically to the asthma, but stridor is specifically to the an obstruction of the upper airways. Now, when the upper airways obstruction by the tumor or laryngeal edema, this is we will have the stridor by auscultation. But if it is asthma, we will hear the wheezing. Okay. If we don't take attention here, we can misdiagnose asthma and the other obstructive disease. Okay. Bronchial obstruction with a foreign body also can even there is a persistent wheezing. This is a persistent wheezing. How will we differentiate it now for bronchial obstruction with a foreign body with the asthma? Why we give drugs? We may be a bronchodilators, we will not have we will still have a persistent wheezing when we have any bronchial obstructive. But with asthma, we give the drugs and the wheezing reduced. Left ventricular failure also can mimic the symptoms of the asthma. There is a wheezing that can mimic asthma, but clear cause are present. Now, the left ventricular failure, we will see this pathology in heart failure. We will understand very well that when we have the failure of left ventricular, with the ventricles. Now we will have the blood will return back to the lungs, and that will create the dyspnea. But we can't have a wheezing here. Maybe we can have a wheezing, but associated with the clacos. We have other clacos also that can differentiate the left ventricular failure and the asthma. The presence of the clacos. Chronic obstructive pulmonary disease can also misdiagnosed with the asthma, show less or no reversible to bronchodilator. But we will tell you that there is a difference. It is not asthma, it is a COPD. We will administer bronchodilator, but the bronchodilators will not reverse the symptoms. What are the medications? Now, the right medications depend on a number of things, including age, symptoms, asthma triggers, and what seems to work best to keep asthma under control. So, preventive, long-term control medications reduce inflammation in your airways that lead to symptoms. Quick relief inhalers, means bronchodilators, quickly open slow airways that are limiting breathing. In some cases, medication to treat specific allergies are needed. So you will see the bronchodilators in the special pharmacology. Okay, let's see pneumonia. The pneumonia is an acute infection of the pulmonary parenchyma. Okay. Despite being the cause of significant morbidity and mortality, pneumonia is often misdiagnosed, mistreated, and underestimated. Etiology of pneumonia. Normally, the airway distal to the larynx is protected from infection by various defense mechanisms. Okay. Yeah. So our airways, the distal to the larynx now, is protected by from infections. So mechanisms that create a mechanical barriers to microorganisms include air filtration, epiglottis closed over the trachea, cough reflex, mucociliary, skeletal mechanisms, and reflex bronchoconstrictions. This is the mechanism that protect the parts, our part of the respiratory systems. Now, yeah. And immune defense mechanism include secretion of immunoglobulin A and G, and the alveolar macrophages protect also the respiratory system. The pneumonia is more likely to occur when the defense mechanism become incompetent or are overwhelmed by the virulence or quantity of infection agent. Because our airways are protected from those highlighted above mechanisms now, but the pneumonia, the infection of the parenchyma or the infection of the lung cells will occur when the defense mechanism become incompetent or overwhelmed by the virulence. When we say the virulence, this is the severity of bacteria. The severity of bacteria now, or quantity infection agent. If you have many infection agent now, we see the pest, we work over now. We fight and we destroy and maybe we'll win. I can say our immunity, our protections now. Decrease the consciousness, depress the cough and epiglottal reflexes, which may allow respiratory expiration of oropharyngeal content in the lungs. Okay, this is a very important point, of course, for the patient with unconsciousness state. This state depress the cough and epiglottal reflex, of course, because the current is not responding. He is in unconsciousness state. Because of that, there will be depression of the cough and epiglottal reflex. That will allow the aspiration of oropharyngeal content in the lungs, into the lungs. That will cause the pneumonia. Tracheal intubation interferes with the normal cough reflex and the mucociliary escalator mechanisms. How this? Maybe you are not yet being exposed to intubation, but you will see in ICUs intubations. Now, this is to facilitate the client breathing for those who are unconsciousness, for those people who are not able to breathe in and they breathe out. We give what we call intubation. We intubate. This intubation, this is the tube. This is the tube now through the mouth until to the bronchi. So this the tube will interfere with the normal cough reflex, and when the normal cough reflex is depressed, now we can't cough out those particles and the microbes, the virus are trapped by the cilia and the mucus. So those microbes can even go up to the lungs and infect the parenchyma cells. Okay, you have to pay attention to this while you are in clinical practice. Yeah. Air pollution, cigarette smoking, viral, upper respiratory infections, and the normal changes that occur with aging can impair the mucociliary mechanisms. Yeah, we have seen that the cilia have an important role, in protecting the entry of the foreign materials. When we say the foreign materials, we account also the viruses and the microbes now, and the dust. Also now, when those microbes now escape mucocilia now because of the cigarette smoking, well, you see, this is like a fire. Now, while you are smoking, we destroy those cilia, and even we reduce the mucus productions. Of course, now we interfere with the mucociliary mechanisms. When the mucociliary mechanism is not working very well, means what the bacteria can escape and reach the lungs. That can cause infection for the parenchyma in the alveoli. Those organisms that can cause a pneumonia, they can reach the lungs through 3 flowing methods. Now, aspiration of normal flora from the nasopharynx or oropharynx. Now we know when we say the normal flora, those are the bacteria. Normally we live it together. They live in the mouth, but they don't cause the disease. But at any time our mechanisms or mucociliary mechanisms is defected. Now we can swallow and we can aspirate those microorganisms in the mouth. So when the microorganisms are alive in the lungs, they can infect the lungs. Many of the organisms that cause pneumonia are normal inhabitants of the pharynx in the head adult. Yeah, okay. Yeah, you can see when the mechanisms of protection are impaired. Now those the normal flora in the mouth can go. You can enter into the lungs and it can cause infections. Inhalation of microbes present in the air also can cause infections. Hematogenous spread from a primary infection elsewhere in the body. When we say hematogenous spread, hematogenous infection, we hear, let's see, when you have a wound, you can have a wound at your leg and your leg will be infected, and the infection will reach the blood circulation and be carried out to the lungs. That will be a hematogenous infection. It's a hematogenous spread of microbes now, and the microbes reach the lungs and infect the lungs, and you will develop a pneumonia. An example, typical example, this is the pneumonia, Staphylococcus pneumonia. Now, yes, Staphylococcus aureus, those are Staphylococcus that mainly or generally infected the wound. But if they reach the lungs, if they reach the blood circulations now, they can even reach the lungs and they infect you, and you develop a Staphylococcus aureus pneumonia. What are the types of pneumonia? Bacteria, viruses, mycoplasma organisms, fungi, parasites, any chemical are all potential cause of pneumonia. Although pneumonia can be classified according to the causative organisms, a clinical effective way is to classify it as community acquired or medical care associated pneumonia. So yeah, you can see we will classify pneumonia as community acquired or medical care associated pneumonia. When we say community acquired pneumonia, is an acute infection of the lungs occurring in a patient who have not been hospitalized or resident in a long-term care facility within 14 days of the onset of symptoms. Amping antibiotic therapy should be started as soon as possible. This is usually a patient that develops the signs and symptoms of pneumonia, but the patient have not visited the hospitals or being hospitalized in the hospitals within in the last 14 days of the onset of the symptoms. Okay, we will say community acquired pneumonia means what? The pneumonia have been the client have been affected by pneumonia in the community. But when we say medical care associated pneumonia, we will have I think three things now. I think three things. We have hospital associated pneumonia. We will say hospital associated pneumonia. It's a pneumonia that occurs 48 hours or longer after hospital admission and was not incubating at the time of hospitalization. What do you mean here? You admitted the client without a sign and symptoms of pneumonia, but within 48 hours, the client begin to show the signs of pneumonia. This will be classified in the hospital-associated pneumonia. Now, ventilator or associated pneumonia. Ventilator-associated pneumonia. This is a pneumonia that occurs often after 28 to 48 hours after endotracheal intubation. The endotracheal intubation is what I told you for the client with the respiratory distress. Most of the time they give a tube, endotracheal tube. They insert the tube from the mouth up to the bronchia, and the tube will be connected to the ventilator, and the ventilator will breathe in to the client and breathe out to the client. Now here, when you put the client under on the endotracheal intubation without the signs and symptoms of pneumonia, and then after 48 hours, the client starts to show you the symptoms of the pneumonia. This pneumonia will be classified in the ventilator-associated pneumonia. We have a healthcare-associated pneumonia. A healthcare-associated pneumonia is a new onset pneumonia in a patient who 91 was hospitalized in an acute care hospital for 2 days or longer within 90 days of the infections. Healthcare-associated pneumonia is a new onset pneumonia in a patient who was hospitalized in an acute care hospital for 2 days or longer within 90 days of the infection, and or a resident in a long-term care facility, received IV antibiotic therapy, chemotherapy, or wound care within the last 30 days of the current infection, or attended a hospital or hemodialysis. If the client develops those symptoms, will be associated with healthcare-associated pneumonia. What we call aspiration pneumonia. The aspiration pneumonia results from the abnormal entry of materials from the mouth or stomach into the trachea and lungs. That will be aspiration pneumonia. Most of the time, this is a fatal. You can even take your tea, the tea in your mouth, and when you want to swallow, and there is a and the T can go. There is a error in the of epiglottis in closing the closing to allow swallowing or to close the air through the airways or mouth. Now if there is such an error, you can those T can go into the lungs. Now it will be called aspiration pneumonia. This condition increase the risk of aspiration, include decrease the level of consciousness. Now if you have you decrease the level of consciousness, it is forbidden to give to the patient, any conscious patient, anything through the mouth, because he can have aspiration. Okay, when you are caring for the client with the decreased consciousness, you will be sure that you will educate the family members to do not administer anything through the mouth. Most of the time, the relatives want to give you water, relatives want to give you the porridge, want to give you the soap. Now you have to avoid them. You prevent for aspiration pneumonia. Those patients with the decreased level of consciousness can be having a seizure or after anesthesia and head injury, stroke, alcohol intake, difficult swallowing, or nasal intubation with or without tube feeding. With the loss of consciousness, the gag and the cough reflex are depressed, and aspiration is more likely to occur for those old patients. Those old patients now with the decreased level of consciousness, please pay attention to give them the anything by mouth. Pathophysiology of pneumonia. Specific pathophysiologic changes related to pneumonia vary according to the offending organism. Some viruses cause direct injury and cell death. The majority of organisms, however, trigger an inflammatory response in the lungs. A vascular reaction occurs, characterized by an increase in the blood flow and vascular permeability. Neutrophils are activated to engulf and kill the offending organism. The neutrophils, the offending organism, and the fluid from surrounding blood vessels feed the alveoli and interrupt normal oxygen transportation, leading to clinical manifestation of hypoxia. We will see tachypnea, dyspnea, and tachycardia. Mucus production is also increased, which can obstruct airflow and further decrease gas exchange. Consolidation, a feature typical of bacterial pneumonia, occurs when the normally air-filled alveoli become filled with fluids and debris. Complete resolution of and healing occur if there are no complications. Macrophages raise and process the debris. Normal lung tissue is restored and gas exchange returned to normal. What can we understand about this pathophysiology? Normally, when there is an cell injury, there will be an inflammatory process. During an inflammatory process, we will see an vasodilation to allow permeability. The vasodilation will increase the permeability, and then the blood will shift from the vessels to extracellular in the interstitial part, where exactly the pathogen is located. So at that time, those fluids will shift from the vessels into the alveoli. That will cause the fluids in the alveoli. And that fluid will interrupt normal oxygen transportation, leading to hypoxia. When you say hypoxia, this is low oxygen in the cells. Hypoxemia, this is low oxygen in the blood. What are the clinical manifestations of pneumonia? Most cases of pneumonia are preceded by an upper respiratory infection. We will see the fever, chills, productive mucoid prevalent or blood-stained sputum or dry cough, malaise, headache, myalgia, and arthralgia. And we have pleural pain. We have also dyspnea and hemoptysis. Hemoptysis is sometimes. When we say hemoptysis, this is the coughing blood. 20% of patients may have gastrointestinal symptoms such as nausea, vomiting, and or diarrhea. Physical examination: dullness to percussion, clacos, egophony. Individuals also may demonstrate signs and symptoms of underlying systemic disease or sepsis. The diagnosis: we diagnose the pneumonia by physical examination and we do the laboratory test. We can test a white blood cells count are elevated. We can even do the microscope of the sputum, and we do the gram stain and the culture of sputum, and you can do the blood culture. Chest X-ray will show infiltrate that may involve a single lobe of the lung. This is lobe pneumonia, or may be more diffuse for both lungs. This is bronchopneumonia. Treatment: antibiotics in the case of bacterial pneumonia. In outpatient previously health and no antibiotics in the past 3 months. Imaclolid, example, clarithromycin, erythromycin, or doxycycline can be used. In the case of comorbidities or antibiotics in the past 3 months. High dose of amoxicillin or ceftriaxone. In the case of hospitalization, we give ceftriaxone. Supportive therapy in the case of viral pneumonia: adequate hydration, good pulmonary hygiene, or deep breathing, coughing, chest physical therapy also are needed. What are the complications of pneumonia? Complications develop more frequently in older individuals and those with underlying chronic disease. Potential complications include the following: pleurisy. The present inflammation of the pleura is relatively common. Now, the pleurisy is inflammation of the pleura. The pleura is a membrane of the lungs. Pleural effusion. The pleural effusion fluid in the pleural space can occur. In most cases, the effusion is sterile and it is reabsorbed in 1 to 2 weeks. Occasionally, effusion requires aspiration by thoracentesis. The thoracentesis, this is a medical procedure done to drain the fluids in the pleural cavity. Atelectasis, this is a collapse airless alveoli of one or part of one lobe may occur. This area usually clear with effective coughing and deep breathing. Bacteremia. Bacterial infection in the blood is more likely to occur in infections with Streptococcus, pneumonia, and Haemophilus influenza. Lung abscess, not common complication of pneumonia. However, it may occur with pneumonia caused by Staphylococcus aureus and gram-negative organism. Also, the complications may have emphysema. This accumulation for the purulent exudates in the pleural cavity and require antibiotic therapy and drainage of the exudate by a chest tube or open surgical drainage. We can have also pericarditis. This is that from spread of the infection organism from infected pleura or via a hematogenous route to pericardium. Meningitis can be caused by Staphylococcus pneumonia. The patient with the pneumonia who is disoriented confused or drowsy, may have a lumbar puncture to evaluate the possibility of meningitis. Sepsis can occur when bacteria within alveoli enter the bloodstream. Severe sepsis can lead to shock and multi-system organ dysfunction syndrome. Acute respiratory failure is one of the leading causes of death in patients with severe pneumonia. Failure occurs when pneumonia damages the lungs' ability to exchange oxygen to carbon dioxide. This is acute respiratory failure. Pneumothorax can occur when air collected in the pleural space, causing the lungs to collapse. Pneumothorax. Lung abscess. Lung abscess is defined as pulmonary parenchymal necrosis and cavitation resulting from infection. The development of a lung abscess implies a high microorganism burden as well as inadequate microbial clearance from the airways. What should be etiologic factors of abscess? Aspiration is the most common cause. Factors that portend an increased risk of aspiration include esophageal dysmobility, such as disorders and neurologic conditions causing bulbar dysfunction. Other predisposing conditions for lung abscess include periodontal disease and alcoholism. Causative agent. Anaerobic bacteria are the most common causative organism for lung abscess. Aerobic or facultative bacteria such as Staphylococcus aureus, Klebsiella pneumonia, Naricidia, and gram-negative organisms, as well as no-bacterial pathogens like fungi and parasites may also cause abscess formation. In the immunocompromised host, aerobic bacteria and opportunistic pathogens may predominate. Clinical manifestation of lung abscess. The symptoms of lung abscess are typical of pulmonary infection in general and may include cough with purulent sputum production, pleuritic chest pain, fever, and hemoptysis. In anaerobic infection, the clinical course may evolve over an extended period of time, and some patients may be asymptomatic. Paramedical exam. The chest radiography should be done. CT of the chest. Laboratory studies may reveal leukocytosis, anemia, and an elevated erythrocyte sedimentation rate. Identification of causative organisms and ideal but challenging goal. Anaerobic bacteria are particularly difficult to isolate. Blood sputum culture and, when appropriate, pleural fluid cultures should be obtained from patients with lung abscess. The complications of lung abscess include brain abscess, emphysema, meningitis, pneumothorax, and respiratory insufficiency. Thank you very much. Merci beaucoup. Murakoze cyane. Mukomeze mutere inkunga iyi channel, mukanda kuri subscribe ndetse no kunzogera, kugira ngo ibindi bikurikira mujye mubibona uwo mwanya igihe tubishyizeho.